we're talking health and wellness on CUTV News. I'm Jim Masters, and thanks for joining us. Today we're spotlighting Dr. Victoria Mondloch. Dr. Mondloch is a practicing physician with close to 30 years of experience specializing in women's health, family medicine, and preventative health and wellness. An OBGYN by training, today Dr. Victoria Mondloch describes herself as a wellness physician, and she partners with her patients to deliver the best health care possible. She says when she tells people she's a wellness physician, well, sometimes it means different things to different people. She feels her job really is to keep people off medications and out of that healthcare system, out of the hospital, and out of the doctor's office. Dr. Mondloch practices hormone balancing to return a patient to hormone levels that are age appropriate. She works with patients who feel like their voice hasn't been heard and they have a lot to say. Her approach is a total teaching empowered approach. She wants to partner with her patients for their health care. In addition to her private practice, Dr. Mondloch is also the author of Blossoming from Girl to Woman, Discovering the Secrets to Balancing Your Hormones and Your Life, a daughter-mother guide. Now, to discuss the book and so much more and all the wonderful work that she's doing, Dr. Mondloch joins me today here on CUTV News. Dr. Mondloch, thanks for joining us here in the studio.
Thank you.
It's an honor and a pleasure to have you here. I mentioned wellness. Now, that is a word that can be generic for a lot of people. How do you define wellness?
Well, again, as you mentioned, wellness is many things to many people. Wellness in my world is I want people to feel like they don't need the physician unless they cannot master what's going on themselves. So wellness is about keeping people out of the doctor's office, out of the healthcare system, which also means off of medications. So if you're on medications and you feel you're not a candidate to be in a wellness doctor's office, think of how you may be able to come off of medications, how you may be able to take a better look at your own health and start to take charge of your own health. That is also my job, to try to empower people to learn what their body is going through and how we can turn back the hands of time and give them back their health.
Now, why is it that you've wanted to take this approach? Did you see that maybe the healthcare system and the way health is provided is going in a different direction, or maybe not a direction that really is patient-centric?
When I started in medical school, I felt that patient care was paramount, and that the patient was put in the middle, and that the healthcare system was around the patient to help take care of them. What happened during the first 15 years or so of my practice is that it was really much more the opposite. The healthcare system fed the healthcare system. Patients were brought in, and it was about what diagnosis they had, how many visits that would generate based on that diagnosis, how many surgeries we could do based on that diagnosis. And it was no longer about the patient. It was about what the system could gain from that patient's diagnosis. So medicine became more hospital-centric versus patient-centric. And if you think about it, the hospital system and the healthcare system really wouldn't exist unless we had patients. But the patient has been basically told that come to my system and I will take care of you because we're smarter or we're better. And it's not really about the patient anymore. It's about the system. And so my feeling is that the patient needs to be re-educated, that healthcare is really about them in the first place, and that they have a choice. They can choose with their pocketbook, with their insurance, where they want their healthcare to be taken care of. And it really is about them.
Which is the key. Doing some research in preparation for the interview, there's some really cool things that I know that you're very strong about, and these are things that are very, very important to you. Things like, imagine a physician's office where you're seated and a wing chair listening to soft music with a mixture of books and health magazines on the end table available for you to pursue while you wait for your appointment. Imagine your appointment starts on time. Imagine having 20 minutes of full face time with your physician who sits next to you in a leather chair at a cherry parquet table looking out the window at an urban wooded setting. Imagine the doctor actually listens to what you're here for, and on and on and on. These are things that you've thought about that are important to you, right?
This is how my office operates. When I have a patient who's a brand new patient walk in for the first time, they actually walk in thinking they're in the wrong place. And they ask the front desk, is this really Dr. Mondloch's office? Well, yes, it is. Oh, this isn't what I expected. They don't expect a marble counter. They don't expect cherry wood. They don't expect to have this leather upholstered wing chair that they sit at and books that they can pick up and read. They're expecting a sterile medical environment. And in my world, that's not the picture of wellness that I want my patients to have. So not only do they have a totally relaxed front office setting, but when they realize that they're being called on time for their appointment, that's saying I respect that patient's time as much as they're respecting my time.
So as opposed to being put in like a secondary room and sitting in that room by yourself for an hour waiting for the doctor to come in, you keep it on time. The other thing I like too that is really quite special is imagine staying out of the medical health care system because your doctor keeps you healthy. Tell us about that.
Again, if I see you as a patient and you walk in, one of the first things I'm going to ask you is, what can I do for you? And that disarms many people. And they don't know quite how to answer that because they say, well, I'm here for, I have a cold. I can't sleep well at night. I have hot flashes. My bladder wants to go to the bathroom every 45 minutes. These are all things that I just need to get a handle on, and I don't feel like my doctor is listening to me. And I'll ask them to rank their symptoms. Of the ones you just gave me, give me the top 3. And they'll give me their top 3. Okay, let's talk about these. And the patient is immediately realizing this isn't about me, it's about them. And it totally places a patient who many times walks in with a body language like this to a body language like this. And they have now realized that it is about them, so they can be safe and they can open their thoughts and they can actually dialogue. They can actually have a discussion with their healthcare provider because guess what? I'm listening. Mm-hmm. In many cases, a patient within the first 30 seconds of a visit with a doctor, that doctor's already assumed the diagnosis that they're in for, and they quit listening to their patient because they've already in their mind come up with the diagnosis that they're going to label this patient and act accordingly and work that patient up accordingly. Instead, I'm spending that time listening to the patient's concerns, their top 3 concerns, and then saying, this is what we're going to do about it. And they're absolutely dumbfounded in many cases because I've had patients start to cry because they realize somebody's listening to them for the first time.
They've never heard this said to them before, more than likely, right?
Correct. And if I say to them, you're on these medications, why? And all of patients look at me and say, I don't know. I don't know what that medication is for. Well, let's see if we can, over time, get you off of some of these medications. And they'll say, I've never heard a doctor say that to me before. So if medicine truly is about the patient, and we truly are going to be honest about healthcare in this country, don't you think we need to have the patient start the conversation and have the patient tell us what they're interested in having happen to them? I am simply the vehicle that allows them to get there. So
here's another one that you have. Imagine choosing having blood work or testing to be done where it's actually most cost effective for you. Now, when we talk about the healthcare system, we don't hear cost effective being associated with it at all.
Well, as an independent physician, I actually have to have value that I add to my patients. Otherwise, they can choose to go anywhere. But as an independent, what I can say to them is, I would like you to have test A, B, and C. If your insurance is going to cover this, this can be drawn at location A, at location B. If your insurance is not going to be covering this, then wouldn't you like to be told that you can go to location A, but it's going to cost you 3 times more because it's a hospital setting than if I send you to an independent setting where it's going to be a much better cost to your pocketbook with the same level and degree of confidence in the lab values that I get. So I trust this lab, which is why I'm making that recommendation. You work hard for that money. Shouldn't that money stay in your pocket?
Absolutely. Absolutely. Imagine having your doctor, your blood drawers, your chiropractor, sports medicine practitioner, and supplements all available in the same office setting where the staff knows your name.
Imagine being able to walk in and somebody says to you, "Hi, Jim, how are you?" Does that happen at your doctor's office? Wow. Then as you're meeting with your physician, you're telling me, "Oh, by the way, doc, I slept funny last night. My back is bothering me, or I'm feeling an increase in headache. I think my neck is bothering me." That we can address that all within a setting that you already trust the information that you're getting from your doctor. Now I can walk you down the hall, and now you've got somebody who can address concerns that you have, and it's all in the same office. You're not being told, "Oh, you'll have to make an appointment for that. That's the chiropractor or that's sports medicine. We'll see when they have an appointment next for you." But I have that pain now.
The pain is now.
Right.
Right.
So why can't we address that now? "Oh, I'm really sorry, they're booked." Wow. So having multiple level services, again, patient-centric. The patient is the reason that we're in business. So put the patient first and have the services surround the patient.
There's another one that I like. Imagine that your doctor explains what your test results mean for your health, both normal health and optimal health. Actually explaining what these tests are, not just saying it was good or you're okay.
Correct. One of the mantras of the electronic healthcare system out there and having patients have access to their medical records means, yes, you can go on your phone and you can check what your lab results were from your doctor. Well, isn't that wonderful and good that you can see that your blood count is normal? But what does that mean in context with where some of your other blood tests are? You're simply told, "Oh, everything looks good." But realize that in a lab reference range, that reference range is the same reference if you're 29 years old, if you're 59 years old, if you're 200 pounds, if you're 150 pounds, if you're 400 pounds and diabetic. That reference range is not optimal for you. It is what the range for the lab is for all comers, all ages. So what does that normal lab really mean? That's what you need counseled. That's what the doctor's role should be is, "Jim, your blood count is borderline low and in context with this other test over here. What I'd like you to do is to start a multivitamin with iron." Wouldn't that be more helpful to you than, "Gee, everything looks good," and then you find out 6 months later that you're low in iron and you could have done something about it sooner?
Or if you hear everything looks good, you go out and splurge and you have all the things you shouldn't be eating and doing because you figured you can coast until the next blood work is done.
Got a good report card. I can go.
Not that anybody does that, I mean.
Oh, of course not.
Right. Here's another one, too, that's this is almost like your Bible here, which I really, really like. Imagine, now this is an important one. I think a lot of people watching would really like this one. Imagine having your doctor recommend that you may be able to come off some of your medications and actually giving you options on how that might look.
Realize that in the healthcare system isn't interested in taking you off medications. That means you may not come back to see them. So they want you on more and more and more. And once you're on a medication, how often is it recommended that you come off? Not very often. So in other words, what would be an incentive to get you off would be to get you healthier in that arena. If it's blood pressure medication, let's actually do things to encourage you to get a better blood pressure. Perhaps that's actually saying, gee, here's a coupon to have 10% off at this health club down the road, and it's not associated with the hospital system, but it's an independent healthcare club. Jim, I want you in that club twice a week, and I want you doing this cardio with this exercise with this, mix it up. In other words, now I'm giving you an exercise prescription. And in the world of healthcare, if I would simply say, Jim, I need you to exercise, then a lot of docs go, whew, check that off my list of recommendations. Okay, but all they said was go exercise. How valuable was that to you?
Most people don't run out and do it.
Well,
they're like, I'll get to that.
Or you may have the best of intentions, but by the time you leave the office and you make it to your car, your phone is rung twice. You've now got 5 things on your mind that you have to do before you get back to the office.
Life gets in the way.
And that was a great thought, but all of a sudden, you know, you don't think of it until the next time you're at the doctor going,
out the window.
Oh, shoot.
Yeah.
Should have, could have, would have.
And didn't.
And didn't.
Here's another one, too, that I like. Imagine being a partner in your own healthcare along with your doctor. What I like about that is the word partner, because we don't necessarily assume or feel that sometimes. We don't assume that the doctor is necessarily going to be a partner in the overall healthcare for ourselves. But that's the goal, and what you strive for is to be a partner. How do you describe what being a partner with your patient is and what that really looks like?
Well, who best knows what you're feeling than you? So if you come in and I've made a recommendation and I say, I would like you to do X, Y, Z, and you come back and you say, wow, I feel really good. Well, yes, that is one form of partnering, okay? But if you come in and you go, Doc, I'm feeling tired. I'm not sleeping well at night. I give you a recommendation and it doesn't work as well as you would like. When you come back in and you say, Doc, I got 50% better, but not as much as I'd like, then if you're not partnering with your patient, you may say, well, we'll just up your medication and that's what we're going to do. Well, if I'm going to have you partner with me, part of that is encouraging you to continue giving me feedback. So instead I'm going to say, well, what do you think worked better? Do you think this supplement worked better for you? How long did you sleep? Did you stay asleep or did you wake up? In other words, now what you realize is that I'm really interested in what your comment was. Not just, Doc, it didn't work well. Oh, here's another, take more, take a higher dose. Okay, my job is done here. In other words, the only way we can partner is if you share with me and I share back what we're going to do. Yes, I'm the physician and I have a little more knowledge base in this area, but you're the one that's having it happen to. And how can I feel what you feel? You have to tell me what the success of the recommendation is.
Right.
That's called partnering.
Exactly. Another thing you do is give people the opportunity to imagine your doctor recommending tests that can happen in the best setting for you, the patient. Tell us about that.
If I have a patient who says, I get really anxious when I go in to have an MRI done, then why not an open MRI? Why not a setting where they actually may feel more comfortable? What if they get anxious every time they walk into a hospital setting? Maybe the hospital is not the best place for that testing to be done. Perhaps an independent setting where it's a much different environment. You have different smells. You have a much more low-key kind of a...
Not anxiety building or inducing atmosphere.
Correct,
right?
Correct. So you can be sensitive to what your patient's needs are while you're still doing the testing that you feel is appropriate for them.
That's great. And again, imagine being told you may actually be able to come off the medication. Are we living in an overprescribed society? Are we getting all these prescriptions to sort of mask the underlying causes? We're treating the symptoms versus the cause of what's creating the symptoms?
I'm going to say yes, but let me qualify that, okay? In Western medicine, what we have been taught as a society is, I have a symptom, I have a pill for that. So you walk into your doctor's office and you say, I have an ache, and they say, I have a pill for that. Oh, that didn't work. I have another pill for that. Oh, well, now I have a side effect from that. Now I've got acid reflux. I have a pill for that. And it's a cause and effect, okay? Because we walk in with what is considered a symptom and we are given a treatment, but that treatment may have side effects. Remember all those commercials you hear on TV? And then at the end, it's almost the auctioneer's voice saying, may cause heart attack, stroke, death. And it's said very, very quickly so that you really don't hear it. But if you really listen, would you take
Worse
that medication?
Than what the pill is for.
Would you take that medication? But then worse, you're on that medication. Let's take, for instance, a blood pressure medication. You're started on a blood pressure medication, and your blood pressure is still higher than the physician would like it to be. Now, you may have a second medication added to it. Instead of realizing maybe the first medication might not have been the best one, maybe we need to stop that one and actually try a different one. But did we add exercise in there? Did we add a change in dietary? Did we do the rest of the prescription, so to speak? Did we do the rest of our homework to try to make sure that that patient's in the best setting to be able for that medication to work for them?
Exactly.
So in many cases, I think the patient is as trained to say, I have this diagnosis, I want a pill for this, because they heard it on television. So that's what they come in for, that they heard this is the newest medication for my symptom, so I want this medication. And you could imagine that in certain settings, if it's a busy office setting, in certain circumstances, they may just be given that medication because they asked for it, maybe not because it was the best option for them.
So the patient asks for it.
Imagine that.
And that's what's an issue with the opioid and all of that situation is happening too, right? A lot of the people are getting hooked on certain medications and they're coming back for them, and it might have been something to alleviate severe pain in the beginning, but then the body sort of adapts to it and craves it more.
Well, and in the opioid setting, realize too that a lot of people come in with true pain. Their initial start on that medication is for a very reasonable diagnosis of pain, whether it's post-op, whether it's an injury, whether it's overuse of an area. Think of a person who, as a mechanic, is always doing something over their head. Then they're going to have neck pain, or they're going to have an issue that causes them to have overuse of a certain set of muscles and underuse of others. That's a real need for intervention, but it may not require that level of pain medication, or in a post-op setting it may, but most people only need a high level of pain medication for 3 days. And after 3 days, you can already start to step down. But again, in a busy office setting, how many times are you looking to decrease a call back to the office, or it's a weekend coming up, so we're going to make sure we don't get a call on a weekend? There can be varied reasons that happen that cause for a prolongation of a script to be done, and all of a sudden a patient is more dependent on that medication, or they're given the instruction that their pain should be 100% gone. Well, pain is a symptom that something is still there. Sometimes pain is a good thing at a certain level to remind you not to overdo something. If you're well medicated and you have pain and you overdo the same procedure or the same motion or the same activity, and you keep injuring an area that you're taking pain medication for, then you really aren't doing anything to help yourself, because you haven't been told a little bit of pain is a good thing.
I know that you wanted to get across in this interview the very important distinction between sort of maybe the way it used to be, where when people went into practice or they went into medical school, it was really about, like you said, the patient and about caring and taking care of people. But then the healthcare system sort of got in the way, and the healthcare system is dictating how things are done and what's profitable, what's not profitable, what we should cover, what we're not going to cover. There could be some, life-changing, needed things that are not being covered by an insurance company. It could be a cancer drug, it could be a surgery, it could be literally anything. And that it's really important for the patients to understand that your approach is to make them centric, them the key component to all of this, and not necessarily that healthcare system and all the bureaucracy and everything that goes on around it, right?
Correct, and I'll give you two examples of that. Let's say that you've got a blood sugar that's a little bit elevated. And when I say elevated, a normal fasting blood sugar is less than 99. Let's say yours is 105, and you went in fasting, and all of a sudden you're faced with, oh my gosh, could I be an early diabetic? Well, coupled with that blood sugar should be drawn a fasting insulin. And most people go, what? Because they've never had it drawn. A fasting insulin is actually your pancreas, your body's response to that blood sugar. What people are never told is if you're going to do a fasting sugar, it should be no more than 12 hours fasting. If you fast 14 hours, then your body is going to break down glycogen stores in your muscle to keep your brain happy, so you don't have brain fog in the morning. So all of a sudden, you've just dumped sugar into your bloodstream that now got checked at 105. But unless you know your insulin value, you don't realize if this is an elevated sugar because you waited too long, or if this is an elevated sugar because it's real. So that's one example. And people are many times, they'll come into my office and say, my doctor told me that I'm diabetic and I need to go to a diabetic educational class because my blood sugar is 105. My first question back to them is, did you get an insulin checked?
Sure.
And they go, well, no, why should I? Because an insulin can actually debunk that elevated glucose if the timing has been wrong. So that's one circumstance, okay? A second circumstance is a patient I was recently made aware of, positive family history of cardiac disease. And what they're told is their initial workup is, gee, let's do a treadmill stress test. Well, that sounds like the doctor knows what he's doing. That sounds like an impressive test. So let's do a cardiac stress test. Well, what you aren't told is that that's a $5,000 test, which has a lot of false positives to it. So now you may be one of those false positive patients that you get a positive on your treadmill stress test, and they say, oh, now we have to add the nuclear part of the treadmill stress test. Well, that's another stress test with now nucleotide brought in, or nuclear medicine. So now we're adding another $7,500 test on top of the $5,000 test. Wait a minute. Where was the screening homocysteine as a cardiac blood marker? Where was the high sensitivity troponin as a blood marker? Wow, those two tests alone can actually be under $300 and give you a better idea of, is there any stress to your cardiac muscle? More than a $7,500 and $5,000. You've just spent $12,500, but you feel so well taken care of because your doctor ordered these really expensive tests.
Yeah. With these big machines.
With these
and all this
marvelous technology. Yeah. Isn't technology great? Wow. But do you feel that you really got your heart looked at as well as it could be? Well, then this same patient said, well, then I suggested a calcium score of my heart. And most people go, I don't even know what that is. What is a calcium score, Doc? Well, it's a CT scan of your heart that will tell you about hard plaque. So if you can do a CT scan at generally a cost of $250, then you can determine hard plaque in the vessels that are putting your heart at risk. Wow, but is it just about hard plaque? No, that is a downfall of a CT of the heart. Hard plaque and soft plaque are part of it, but if you can do 2 blood tests for under $300 that tell you about heart muscle risk, and you can look at hard plaque, you've spent now $500 with your insurance company, and you have more information than you have if you've done the $12,500 testing, which doesn't tell you anything about the plaque in your blood vessels. Because the test after your nucleotide stress test is a cardiac catheterization. Oh, then we know everything that's going on with the vessels around your heart. But the cost of that procedure is about $15,000.
That's big.
So imagine having a little chest pain, ending up in the emergency room, and the sequence of what happens to you is the treadmill stress test followed by the nucleotide stress test followed by cardiac catheterization. Your chest pain, which may have only been some acid reflux, now costs your insurance company $30,000 when you could have tried a Tums first.
And we wonder why healthcare costs are so out of control and skyrocketing.
And the patient doesn't see a lot of
No,
that
they don't.
cost.
They just follow
They
along
just
with-
know what their out-of-pocket cost is.
Right, the copay or the deductible or whatever
Correct.
it may be.
But in the end, what it ends up being is your insurance rates are going to go up because your insurance company just spent $30,000 on one symptom on one day of your life. Wow.
Yeah. Here's something else that you talk about that is connected to all of this too, where each diagnosis that a patient presents is assigned a worth. How many office visits a year that diagnosis will actually generate.
In healthcare systems, what most people don't realize is that patient diagnoses are treated like an actuary is for life insurance, and they're assigned a value. So if you come in and you have a diagnosis of high blood pressure, that insurance or that healthcare system rubs its hands together and goes, wow, okay, that's a primary care doc, but that's going to result in some cardiac issues. So there's the cardiologist that gets involved, and that's going to result in, we're probably going to see some renal damage that's going to happen down the road. So there's the nephrologist. And how many visits a year is that going to generate for this healthcare system? So this patient with this diagnosis is worth X amount to us. And medicine is a business. And hospital systems run it like a business. They used to be run by physicians. Heads of hospitals used to be physicians. That is not the case anymore. It is a businessman who runs the healthcare systems.
So you can say, like, each new diagnosis may represent a new specialist that's brought on board, and they're all working together to keep them within the hospital system. Now you're a physician, you're a doctor. It is a business, so for you it's a business as well. So how do you make that balance between keeping it as a business, but at the same time being able to provide ultimate care and making it patient-centric?
I still have to pay my staff, of course. I still have to pay for the marble counters and the wing chair that are in my front office, okay? But by the same token, I give value-added care. And for a lot of my patients, they don't walk in and hand over their insurance card. They may, but they may decide that even if you're not in my insurance, I am going to pay the rate that you have, which is a reasonable rate. I don't charge what a specialist at a teaching center would charge. I'm considered a medium charge for my services based upon what my billing company tells me. But they're coming in because the value that I can add to their health care is worth it to them. We all know that we could go out and buy a low-level car or a medium-level car or a high-level car. what helps drive our decision as to which car we're going to make is the value that we're going to get. It's a formula in our head. You know, the gas mileage, as well as comfort, as well as how long am I going to hang on to this car, and what do I really want from this car. It's the same relationship when you walk into a physician's office. It should be, what value do I get from this physician? What do I hope to gain from them? Am I looking for another person to just tell me what pills I take and I march down that road with blinders on? Or do I actually have somebody who's going to listen to me and who's going to help me through the issues that I'm going through, so that this is somebody that I can feel comfortable seeing today, seeing next year, seeing 5 years from now, still walking in, and it's still as comfortable a relationship as the day I walked in for the first time.
Now, this is interesting, something that a lot of people might not realize, that physicians are actually penalized if they refer a patient outside of the hospital system, even if they feel the patient's interests, would be best served being seen outside the system. Some physicians sometimes are actually penalized and discouraged from that. That may surprise a lot of people.
It will surprise a lot of people. And what most patients don't realize is that if you're working for a hospital system, and if I, as a physician working in that system, feel that the best doctor for you to see for your special need is this physician at this different hospital system, I have now gone against my boss, and my boss doesn't like it when I take money out of their pocket. And if I make that suggestion and that becomes known that I've made a recommendation outside the system, that physician is not really in charge. The boss, the system is in charge, and they will get talked to by the boss. They will get penalized. And that can start with one offense, second offense, third offense. And if most physicians are taught to be independent thinkers. That's what you go to medical school for. That's what you do your residency for. And you are taught to problem solve. So if you are truly doing medicine for your patient's best interest, and you feel that that patient would be best served outside of your system, you now have a dilemma. What am I really going to do? Am I really going to send my patient where I think they belong? Or am I going to just swallow my pride and my tongue and say, I'm going to send you in the system to somebody else, but that's really not where I want to go.
Do quotas really exist?
Absolutely. You'll just never hear about them.
Really? They do?
They do.
Certain amount of patients per month, per day, what have you, or procedures? Or
correct.
Really?
Best epitomized in an emergency room setting. If the number of emergency room patients per month doesn't equate to X number of admissions, then the emergency room staff is talked to.
You were even telling us off camera about like a colonoscopy and what happens with those?
Well, think about one of the most common recommendations in wellness medicine these days is a screening colonoscopy at age 50, okay? So at age 50, we dutifully line up, and high risk, low risk, positive family history or not, everyone, quote, needs, quote, their colonoscopy. Well, let me walk you through that for a minute. First, a colonoscopy requires a prep. A prep is going to be usually a day, and then the next day is the test. So now you've taken 2 days off of work. 2 days off of work, okay?
Drinking that chalky orange liquid.
That then gives you its results. So then you go in, and let's say that you are a low-risk patient, which means you have no GI symptoms, you carry no GI diagnosis like irritable bowel or Crohn's or GERD or any other GI labeled kind of diagnosis, and you have a negative family history of colon cancer. You are now a low-risk patient. You are prepped. You are taken to a procedure room, light sedation, and within 20 minutes you are back in the post-procedure room, told you have a clean bill of health, and now you feel vindicated that, yes, I am healthy, okay? Well, where have you talked to a physician anywhere through that course of 2 days B, do you remember that you were told it was a clean bill of health? No, you were still under sedation. You were given a piece of paper that says you have a clean bill of health. And C, where are the recommendations for what you should do for proper diet, exercise, proper lifestyle so that you won't build polyps and you can still be a low-risk patient in the future? You aren't given any of that, okay? So now take that business of medicine and realize that the cost of a colonoscopy is about $5,000. Think of a university center or hospital center that has a GI area that may have 10 rooms. If a low-risk patient population has 20 minutes per colonoscopy add in turnover time for the room, each room in a GI center may service 10 patients in a day. 10 patients in 10 rooms in a day, even if they're all low risk, is 100 procedures at $5,000 per procedure, and that GI center is making $500,000 a day. Wow. Now, let me back that up for a minute. And you say, yes, but I know I don't have anything to worry about. Let me tell you what I do at my office. If you come in and you are 40 and we're doing your exam annually, which everyone should have their annual exam, male or female, then a hemocult or a check for blood in your stool is what is easily performed as a part of your physical exam. It has a developer added to a portion of your stool on a card that will develop blue if there is blood, hidden or visible blood in that stool specimen or not. That card to your insurance company costs $25. And now you have a physician telling you yes or no. You have recommendations from your physician about what you can do about it, and I can do that test annually from age 40 to 50, so you now have 10 years of reassurance that you are not only low risk, but you show no signs of, and for 10 years you have been given recommendations by your personal physician about what you can do about it. Which do you think is the route you would rather go?
True. And you're being told, bottom line, you're good to go.
By your physician.
Yeah.
Without losing 2 days of work.
Without all of that.
And all of that cost. Yes, I'm not visibly looking inside that colon, but if there's an issue, that's going to come up over that 10 years or annually from there on, that we'll be able to decide whether it might be time. Yes, now there's a need for a colonoscopy. Now we're back to what it was 30 and 40 years ago, where we are doing testing upon appropriateness.
I want to talk also about the fact that you have your practice in Wisconsin, right?
Correct.
But you also have the ability, and you have a lot of patients that you work with who are not in Wisconsin. How do you do that? Is it over Skype, phone? How are you able to treat and work with patients
That's
coast
exactly
to coast?
right. And where those patients come from is that I take care of you. You come in and you go, oh, you really, my brother would really benefit, or my sister would really benefit from seeing you, but they live on the East Coast. No problem. They can go online. They can get the paperwork needed, send it back to the office via email attachment or fax or snail mail. If we do, therefore, a phone or Skype interview over the phone, then that can discern their areas of need and concern, whether I'm sitting across from you and next to you at a table, or whether we're having a phone conversation or a Skype conversation. I can make the recommendations for testing and or blood work, send that lab requisition to you, again by snail mail or email attachment. You download it, take it into the lab that you know your insurance will cover, get your blood work done, we get the results, you get the lab results to look at, we do the same Skype or phone follow-up, and now you have the same benefit as if you were sitting right next to me.
That's incredible. Wow. That's amazing, huh?
So,
now we've entered the new millennium, the new way of doing everything. Wow. And people really like that, right? They derive the benefit from that.
They do, and I'm going to tell you about a patient of mine that I met 4 years ago at age 71. And when I first met this woman, she thought that there was no reason to be talking to a female hormone doctor. I'm menopausal. There's nothing, I went through menopause 20 years ago. There's nothing you can offer to me that will make a difference. And I said, well, I'll determine whether that's the case or not, but let's talk. What is going on with you? Well, I came to find out she had 13 physicians with multiple diagnoses, and I challenged her and I said, again, what are your top 3 concerns of what you have? And let's do some of your foundational hormone blood work. So I think more to humor me than anything else, she said, well, okay, I'll agree to that. So we did her blood work, and lo and behold, I found that she needed to have some hormone back into her system, and she challenged me. And she said, but doc, I'm 71. I said, you are 71 years young. And so let's put some baseline hormone back into your system. So in the beginning, when I first met her, she was doing 2 naps a day to make it through her day. Fast forward now about 2.5 years, and we're doing a phone follow-up on her labs, and she says, doc, before we start, I want to tell you 2 things. Okay. She goes, number 1, I'm training for a half marathon. And I said, that's great. Wow. She said, I'm being smart about it. I'm working with a trainer. I'm working with a nutritionist. I'm not pushing myself too hard. We've got a training schedule, and I feel good about the cause I'm going to be doing this half marathon for. So I really feel strongly I'm going to do this. I said, good. Okay, what's number 2? Well, doc, I really thought these hormones were going to give me more of a wow factor. And I didn't say a word. And she goes, doc, you still there, right? I said, yeah, I'm still here. She goes, what do you think about that? I said, well, I'm going to remind you how we first met. You were taking 2 naps a day to make it through your day, and you had 13 doctors that you're now down to 3? And she went, oh, wow. I said, there's your wow.
Mm-hmm. There's the wow.
There's the wow.
She got the wow. And a wow that really pays off. I mean, a wow that...
and it was her wow.
Yeah.
She knew without realizing, because it's not that you start a treatment regimen and feel like the Energizer
All
Bunny.
of a sudden,
I can tell I took my medication.
Right, and I feel, yeah.
You should have it be just a part of your day.
It's about balance, right?
It's about balance.
Absolutely. Shift gears a little bit. You were talking about the adolescent female. I know, of course, a major part of the work that you do is working with adolescent females, and you consider them almost sort of like the forgotten demographic, right? Adolescent female. Tell us a little bit about that, and then we'll discuss the book as well.
Well, in the world of women's health care, you always have to factor in that we go through puberty, we go through our menstrual career, and then we go through menopause. And most of health care is diagnosis driven these days, as we've talked about earlier. So if it's diagnosis driven, then in women, you're either prepubertal, which means you're in the pediatrics office, or you're having problems with your period, cramps, heavy clotting, or you're having babies, or you're having pain, or you're in menopause. PMS doesn't get enough press, so to speak. It's just, oh, go to your room, or oh, I need an antidepressant for that. But the adolescent, being that they have 1 foot in childhood and 1 foot in adulthood, and they keep testing which world they want to be in, and they test it, of course, at school, and they test it at home, and as parents, we get tested as to which foot they're in and which camp they're in on any given day. Mm-hmm. But adolescents are going through a lot of the same gear up of their female hormonal system that their moms in their 30s and 40s have not only gone through, but are now gearing down with. what women are never told is that their menstrual career is like a bell curve. And so women in their teens are never studied. Whoever checks hormone levels on the adolescent? They either are in the pediatrician's office, which is, what is your weight, what is your height, are you on the growth curve, do you have your immunizations? Okay, good, next. And it's a rapid fire system that the pediatrician's office is set up for. And they're set up for child wellness. So if an adolescent comes in and throws a cog in the wheel that says, oh, I've got cramps, the pediatrician goes, we have a pill for that. Okay?
And is it always the 3 ums?
And of course, the mom wants answers, but we're at the pediatrician's office. So their only answer may be birth control pills, which the mom feels, well, okay, I did that, so okay, that's fine, that's safe. But where in there ever comes, let's investigate why you might have cramps? It's not every woman who's in their early startup of their adolescent career gets cramps with their period. So why is the pill the answer? Or you have an athlete, the adolescent athlete, who stops having her periods because she's very athletic. Then the answer to that may be the pill as well. Or they may say nothing because they like not having their period until they come in with shin splints, which are really mini fractures, which is kind of like mini osteoporosis, which nobody ever tells you that that's what's going on. So all of a sudden, we have healthcare concerns going on, and we have a very busy pediatrician's office that really is ill-equipped to handle that age of and that level of patient concern. They're set up for that rapid growth. Are we on the growth curve or not? So my premise of the forgotten female is that we take our adolescent daughters and we basically say either buck up or go to your room, it's PMS, or then when they get to their room, what are they doing? They're on their phone or they're on the internet, and they're asking the internet for answers.
Figure out what the issue is.
Is that where you want your daughter getting her advice? Maybe not.
No.
Maybe not.
That's what's great about this book, too, because it really, like you say, it's the groundbreaking truth about what's really going on with your body, information that you won't find on the internet. And it's an interesting read, too, because it's really covering the journey of an adolescent woman who finds herself experiencing a lot of these things for the first time, right? Tell us about this book, and what was your inspiration for writing the book?
The inspiration is really that as I would both see my mom patients in their 30s and 40s going through the struggles of hormone shift and change that they go through with perimenopause, that they would describe their daughters going through similar symptoms but not recognizing that they're the same symptoms just at the beginning of their menstrual career. So what I do routinely is recommend, why don't we check hormone levels on your daughter? Her periods are irregular, they're heavier than they should be, and let's find out if there's an imbalance going on. And for a lot of those moms, it's a light bulb that goes on. Wow, will you do that for me? Of course that makes sense that we would also do that with my daughter. I'm also the mother of 3 wonderful daughters. That is, my 3 girls went through their teens and adolescence. They went through a lot of the same crazy symptoms that I was going through with perimenopause. And that was my first aha moment that, wow, what I'm going through is what they're going through.
Walk the walk, talk the talk,
right.
literally.
So in our house, yes, mom was already the expert, But what about all these other households where the mom is doing her job and her second job when she gets home as mom, and she's burning the candle on both ends? When does she have time to really advise or talk to her daughter? Maybe 5 minutes in the morning as they're both scrambling to get out of the house. So when does that daughter feel comfortable asking their mom for advice about cramps? Or, I'm having a bad day. Oh, take an extra Advil. I'm sorry I'm late for work. You know, we have to give our moms and daughters in kind that opportunity to partner. Again, now we're partnering, but we're allowing the mother-daughter partnership to become the center of what that adolescent daughter is going to experience and go through, and allow the mom, who is that sage with that information, to become the expert for her own daughter. Think of that marvelous bonding that can happen. And one of the comments that I got from one of my staff who was reading the book as we were putting it together said to me, my mom and I were reading this book, and she's adopted, originally adopted as a child. And she said, even as a 30-some-year-old woman reading this with my adoptive mom, we both looked at each other and said, wow, if I only knew what you were going through as a teen, and if I only knew I could have helped you through this, I never knew you felt this way. So valuable.
If I only knew.
If I only would have, could have, should have.
Right.
And we are in our family relationships, and sometimes we miss that magic moment because all you get is 5 minutes in the morning, and you've got 5 things on your mind, and that question your daughter just asked you, can we talk tonight? Well, now the daughter feels dismissed. And instead, it's really, I need more time to think about that, but allow an environment that talks about the mother-daughter bond. Bring, therefore, your adolescent daughter, and my recommendation is, Mom, let me arm you with that information. So bring your daughter in at age 12, at the beginning of puberty. Bring them in again at age 16, and let's do hormone balancing. Let's see what your concerns are, daughter.
Together.
Let's look at this together. You're still a minor. You still need your mom in the room. So let's talk about this. And now mom is the sage. Mom is now brought into this discussion as someone in the know, as someone who's trusted, as someone I can ask this question because you heard from the doctor that this is what's going. So we can work through this together.
Forming or cementing that mother-daughter bond.
Right.
So that's that element of this that is terrific. It isn't just the medical information or trying to disseminate what's really going on. That's part of it too. But underneath that, it's creating that mother-daughter bond, which is essential because, you know, the mother can relate to the daughter can now understand and relate to the mother, and that's really crucial to all this, isn't it?
And now we've taken that false expert out of this, out of the picture, the internet.
Right.
Because the internet will have great information, but that's not really where you want your daughter going.
It's not one size fits all, right?
Right.
It's an individual situation.
Right. And you want somebody that you know you can go back and ask another question to.
So this book, which you describe as the owner's manual for the transition from young adult to womanhood, again, daughter-mother guide, follows the story of one particular woman, and this is a part of a 5-book series that you're working on?
Correct. The way that I've practiced is I went from the traditional OBGYN where I did lots of surgeries and procedures to stepping back. I used to do 4 to 5 major procedures and 7 minor procedures a week. That was a lot of surgical activity that would happen, so that now when I can actually deal with hormone balancing and wellness, I can actually, and I have only referred out 2 to 4 patients a year for surgery. But knowing that it's a wellness-based practice, I can follow a patient, especially a female, through her adolescent years, which is this guide, the adolescent guide. Then it's the issues that face the woman who's 20 to 35, when we're actively having our children and our families, and we hope we have no issues, that we can just get through our day, get through our month, not have to excuse yourself from a meeting to go to the ladies' room because of a near accident. That's going to happen. Which endometriosis, fibroids, those are all issues that can happen. Polycystic ovary, that really nobody ever tells you it's about hormone imbalance. They simply wait for the issue to happen. Oh, you have a fibroid, now we have a diagnosis, and we can do something about that fibroid. Oh, a surgery. But they never tell you it's a hormone imbalance, and that if you balance your hormones, we can actually decrease the size of that fibroid, and we might actually have that not cause a problem for you, and you didn't need surgery. There's 3 in the same sentence. Wow. Or in the 35 to 40-year-old woman, that PMS at its extreme in perimenopause is something that's really a hormone imbalance. And that if we can work with that hormone imbalance, we can actually be a much calmer person. And that female-male hormone ties to adrenal, which ties to thyroid, which ties to insulin, which even ties to vitamin D. That family of hormones is our baseline health. And then when we get through that perimenopausal hormone swing, holy smokes time, where one day you're normal, the next day you're not yourself, and people around you remind you you're not yourself, and then you're back to yourself, and then you're not yourself.
And they're not helping you, they're going the other direction. They're like, leave her alone.
And they don't know how to help you. Correct.
Right. They don't have the tools, right.
And you don't have the tools.
No.
So let's arm you with the information so that you can understand what this whole crazy dance of hormone swing is in perimenopause.
Because there's a lot of things tied to it, like you're talking about, the heavy irregular periods, there's possible miscarriages. There's a lot of things that go on, the recurring cysts in the ovaries.
Right, and all of that's hormone imbalance.
It's all part of.
Nobody tells you. But then that menopausal woman who medicine says, oh, you're menopausal, the curse is gone, get out of here. Unless you have heart disease or diabetes.
Yeah.
But OBGYN goes, oh, well, you're done with all that. As my mother was told, there's nothing more I can surgically take out of you, so I don't need to see you anymore. Imagine being told that by your physician.
It's pretty much a write-off, writing them off.
So there's the second forgotten woman, is the menopausal woman. But
and that can happen at various ages too, right? You're hearing younger and younger sometimes. They start early.
And
what's causing that?
You'll hear the term premature ovarian failure or premature menopause.
You're hearing that.
Well, I'll see a number of those patients, and what it is stress. Their cortisol is
it's sort of kicking them early into a menopausal
stressing
stage.
their ovaries into this stage of non-functioning. So I'll do their hormone balancing, restart them on hormone, and then lo and behold, they come in and they go, but doc, I just had a period. What is that all about?
How could this be? Yeah.
It's like we're starting the machinery back up. It was stressed, and it's back. Wow. Because with premature ovarian failure, premature menopause, also comes premature osteopenia, premature osteoporosis, premature heart disease. All of the things that happen when our hormone goes away happens sooner. Wow, nobody ever tells you that either. Or what men never hear, because my 5th book is about male health and the andropause versus menopause that men go through.
So that's like menopause, but the male.
But it's the male version of, is that they get the same issues with fatigue out of proportion, muscular aches, bladder issues, insomnia, migraines, and it's their male hormone levels dropping. They don't go through periandropause, where you get swings, but they still get that steady drop. And in men, it's whether or not you started at 80th percentile of testosterone, Or did you start at 50th percentile? Or did you really start at 100th percentile? Where
did you
you
go out
start?
and buy that red sports car?
And at what age did you buy that red sports car?
Some things never change, I guess, right?
Amazing, isn't it?
That's funny. So the menopausal woman, I know that's, like you're saying, that's a big component to everything that you do as well. We're always thinking of that being somebody who's a lot older where that kicks in, but not necessarily the case, right?
Not
Like you say,
necessarily.
certain things, stress can...
Correct. And so what I will say to even my menopausal patient when they come in, they will be referred in by another patient, or they hear that hormone has helped them, and they'll say to me, but what is hormone going to do for me? And there are ranges for female hormone that are considered the appropriate range for menopausal women to be in, and you still balance those hormone levels, okay? So I don't want to have a menopausal woman on hormone be estrogen dominant, or she's going to have perhaps a bad mammogram, or perhaps she's going to kick in hyperstimulation of an ovary and build a cyst, or suddenly start bleeding and now it's uterine cancer. So you still have to balance those hormones, but if I can keep a menopausal woman within menopausal norms, then those are similar to norms that they were passing through when they were perimenopausal from age 45 to 50. So if I can say to a woman who walks in, who's 60 or 70, and they say, but doc, what is this going to do for me? What I can honestly tell them is, I can turn back your hands of time. Would you like to be 45 to 50 again? I don't know any woman who would say no to that, because it's not 45 to 50, wow, you're suddenly going to go out and ski the Alps and not break a leg, but you're going to feel the way your body felt because you had hormone in you at age 45
the energy,
to 50.
The health, the stamina.
Right. You're suddenly going to sleep
passion.
through the night. You're suddenly not going to have a bladder that talks to you every 45 minutes. You're suddenly not going to be, trimming your sideburns because you've got more male hormone on board. The dirty little secret of menopause is that there's more male hormone on board.
That comes into play, yeah.
So you suddenly gain 5 to 10 pounds where you don't want it, where you can least get rid of it because you don't have the hormone balance working for you, it's working against you.
Vocal changes too, the vocal changes happen.
Vocal changes, your hair thins, and now your hairdresser is going, oh, you gotta stop washing your hair so often. Well, for a lot of women, their hair is their crown. That's what they take a lot of pride in.
Thinning eyebrows, all
right.
these things that happen.
And so how do I get that back? Well, sometimes it's simply as simple as balancing your hormones and becoming more female again. I take menopausal women from being hormonally male back to hormonally female.
So the two things I'm taking from this incredible detailed conversation with you, doctor, is your overall desire to make health care and wellness as a wellness physician accessible, affordable, relatable, user-friendly, and make it patient-centric. That stems and, of course, flows beautifully into your work as an OBGYN, having that training and all of that experience, and that you're working with folks who feel as though maybe they're not being heard, they're not being understood, people aren't taking the time or the effort to explain certain things, they're just going according to almost like an assembly line sort of situation. And that when it comes to specifically women, from adolescent all the way up to menopausal women, that there's different approaches and different ways to look at it, and that the hormone replacement is an essential component in all of this, which can make their lives a lot better, happier, healthier, feel 40 to 50 again. What is it about hormone replacement or therapy that makes it semi-controversial, where everybody isn't just going out and doing that, but yet you're such a really strong, definitive proponent of it?
Well, I'm going to take you back to when medicine wanted to answer that question. And they set up, back in 1995, the Women's Health Initiative. Huge study that involved over 200,000 women in multiple arms of the study. And their premise was to show that hormone replacement in menopausal women took the top 3 leading morbidities and mortalities and made those better. The top 3 were heart disease, stroke, and breast cancer. Okay? So they embarked on this mission of showing that postmenopausal hormone replacement was going to decrease all 3. And it was meant to be a 10-year study. And the Europeans said, us too. But we don't want to use what you're studying your women on. We want to use different hormones. And we can't enroll as many people, so we have fewer patients, so therefore we're only going to look at breast cancer. So the 10 years, are merrily going along, and at 7, the American doctors said, we want to take a look at the data. We want to peek and see if we're close. So behind closed doors, the docs are looking at the data and they're going, uh-oh, oh shoot, or worse. And the reporters are at the door listening to them go, oh shoot. And the doctors aren't coming out. So the press took their bullhorn and said, women, get off your hormone. I can tell you exactly when that was, August of 2002, because our phone started ringing off the hook. Doc, you've got me on this hormone, and I am having an increased risk of breast cancer, increased risk of heart attack, increased risk of stroke. What are you doing to me? That's what came across, okay? The Europeans looked at their data and said, we're not seeing that. What's the difference? Well, the difference is the hormone that was used. In the American study, women were put on Premarin and Prempro. Now, Premarin is an acronym for what it stands for and where it came from. And most women are never told that Premarin means pregnant mare's urine. Oh, pregnant horse pee. Right. Wow, well, it'll have hormone in it.
Talk about a wow moment.
But we aren't horses. We are human. The other hormone that American women were put on was Prempro. Prem for the Premarin, there's our pregnant horse pee again, and Pro stood for a synthetic medroxyprogesterone that was actually a, whether it's in a pill form, it's also in a shot form. That medroxyprogesterone, or Provera is its other name, is an artificial progesterone called a progestin, kind of a made-up name, a progestin, and it is that Provera that was the cause of the breast cancer risk, heart attack risk, and cancer, or stroke risk, of those 3. But they've never come clean and said that to the American female. So guess what? That shot that I talked about, that Depo-Provera shot, is the most common contraceptive on every college campus in this country. Why? Because it's one shot every 3 months. Easy. Come into student health, get your shot, get on your way. Easy. You're contracepted, do your thing. But what they don't tell these college-age girls is you're going to have an increase in migraine profile, you're going to be more depressed, you're going to be moody, you're going to gain weight. Oh, and by the way, 20 years down the road, you're at increased risk for breast cancer, heart disease, and stroke. So the Europeans instead didn't put their patients on Premarin and Prempro. They instead used the human-based, wow, what a concept, we're human, based estradiol, which is the estrogen our ovaries make, and progesterone, the second female hormone our ovaries make, which you'd say, well, maybe they weren't available in the U.S. at the time of that study. Yeah, they were. They just chose not to put them in the Women's Health Initiative. Interesting. Okay, so we were limited to 2 hormones versus the options that were available, and the Europeans chose the human-based bioidentical hormone. So at 10 years, they looked at their single factor, breast cancer, and found a 0% incidence increase in breast cancer. 0% incidence versus Americans saw an increased incidence. So the Americans said, you can't say anything to us because you didn't do the heart attack and stroke study. You have nothing to say to us. So the Europeans did the cardiovascular study. And the British reported on it in 2012, 10 years later, from when the Americans halted their stuff. And their study showed that in women who started hormone replacement, they had an increase in longevity, wow, and a decrease in heart attack, stroke, and blood clot. Now the Americans went, oh, shucky darn.
Because that's 10 years of lives involved.
That's now 10 years that refuted the cardiovascular that the Women's Health Initiative said was there. So the Americans did a 3-year study called the KEEPS trial, which is a Konos early estrogen and progesterone study. And in this KEEPS trial, what they did was actually compare what the Premarin, taking out that progestin, the Premarin versus the estradiol with a natural progesterone would do. In other words, taking that offender Provera out of the picture. Guess what they found? Many favorable effects. What a surprise. They found decrease in blood pressure, increase in bone density, decrease in heart disease, many effects, decrease in insulin resistance. In other words, many positive effects because we were using human-based bioidentical hormone, to the point where an American study then done in 2015 came out and said, okay, we're going to look at the effect of cardiovascular, called the ELITE trial, at early versus late intervention trial with estradiol. There's ELITE, early versus late intervention trial with estradiol, from a cardiovascular standpoint. Early, 3.5 years postmenopause. Late, 14.5 years postmenopause. Those women who come in that are in their 60s or 70s, saying, why would you even start this on me?
Right.
Okay. Well, in those early patients, and actually when they did a further meta-analysis, meaning not just their patients but other studies, they found that in women who were started on hormone replacement at age 60 or less than 10 years from menopause, you ready? Found a 32% reduction in coronary heart disease and a 39% reduction in total mortality. Now, in medicine, pharmaceutical companies would be thrilled if they could make that claim. And I'm going to be so bold as to say that the only thing in medicine that gives a 32% drop in coronary heart disease and a 39% reduction in total mortality is food, water, and oxygen. The basics. What are our female hormones? Our basics. Think about this fact for a second. Menopause has only been a term that's been around for 100 years. In 1912, the average lifespan of the American female was 48.5 years old. We hit menopause and we died. It didn't exist. With the advent of antibiotics, anesthesia, so we had safe surgery, and many other breakthroughs that medicine has been afforded, we are living longer, we are living healthier, but women still go through menopause, boom, at age 50. Wow. Women today may live as many years without hormone as they did with hormone. Women routinely live into their 80s. That's 30 years post-menopause when it was 30 years of hormone before that. Why is the benefit of hormone that we had from puberty to menopause so good for us and then suddenly so bad for us? Why is that same hormone suddenly a demon? Why is it suddenly bad? Well, what's bad is the artificial. It's the fake. It's the synthetic. It's the progestin. And to this day, what is considered the gold standard when you talk about women's health studies is still the Women's Health Initiative. It is still used as the gold standard, but that still has the progestin, the artificial progesterone in there. We aren't being honest with our own patient population, and we aren't being honest with ourselves. And are we really not being honest because we don't want to admit that we could have done it differently?
It sounds like you're really thinking outside the box. You're revolutionary, innovative. You're on the cutting edge of a lot of different things that people inside already have the answers to, but haven't been releasing at large.
Europe has this thought process. They look at us and wonder why we do things the way we do. Because they don't.
Because usually we're the ones on the cutting edge too, you would think.
Well, we'd like to think we are.
Right.
But in this instance, are we?
So what is your hope with all of the work that you do in changing lives? We talked about the health and wellness and how you define wellness from your perspective, which sounds like a terrific way to define it. And then, of course, your work with folks who are dealing with these other issues of menopause and premenopausal situations, adolescent females, as an OBGYN. What is your overall goal for what you do, your practice, and how you're touching lives?
That's a great question. My husband actually asked me the same question. And
he's a good man.
He is a good man. I've been with him for almost 40 years now.
There you go.
Very good man.
Congratulations.
Thank you.
What's that secret? We'll have her come back in the studio. She'll tell us about the secret of a 40-year-long marriage. That'll be part 2 of our interview. Stay tuned, right? That'll be another book. Yeah. How that happens.
My hope is that we actually, as a healthcare system, take a step back and reassess what we're really doing and what I want women to do. The healthcare system is happy where they are. They're feeding themselves, and like anybody who's, well-fed and happy, they're not looking to change. It's the people who aren't being serviced well by the medical community that are not happy and well-fed and are looking for answers. So my hope is not that medical schools are going to start to teach this. They have no interest in teaching this. My hope is that the female out there, the patient who feels that their doctor isn't listening to them, realize there are doctors out there. There's doctors like me who are actually going to give you some grassroots information, some help, and even though I may be located in one clinic, my hope is actually to have that clinic reproduce and be franchised in a number of places around the country. But my hope is that patients go, wow, I could contact this clinic and I could have the same hormone balancing even though I live in Virginia, or I live in Florida, or I'm in Texas, or I'm in California. You don't have to be a half an hour away from my office to get the same benefit of information that I can share with you about how I can teach you and empower you to help you with your own health care.
You don't have to be in Waukesha, Wisconsin.
It's the best kept secret in Waukesha, Wisconsin.
See?
So.
And now the secret is out on CUTV News. Doctor, it was a real pleasure and an honor to meet you.
Thank you.
We should continue success with this incredible book, Blossoming from Girl to Woman. Again, this is part one, sort of, right, of an ongoing...
Part one of a five-part
series. That is fantastic. Continued success in getting the word out and taking care of so many people as you do so beautifully. It was a pleasure meeting you.
Thank you. Thank you for having me.
We'll see you again soon, I'm sure. If you'd like to learn more about our special guest, Dr. Victoria Mondloch, and her new book, Blossoming from Girl to Woman, visit her website, victoriajmondloch.mdsc.com. For all of us here, I'm Jim Masters. Thanks for joining us. This is CUTV News.